Hi, my name is Kim Gerke. I am a hospice nurse working in the Milwaukee area. Today I would like to talk to you regarding terminal illness and care of the hospice patient. First, I'll give you a little bit of what hospice is. Hospice is a philosophy of care, and the goal of hospice is to give comfort and dignity to someone who is dying. Who is eligible for hospice care is someone who is terminally ill with the prognosis of 6 months or less. Hospice care can be provided both in the home, in the hospital setting, long-term care facilities, or in freestanding hospice residential facilities. What is available in hospice care is you are given care by a team of caregivers, nursing staff being that of the RN case manager, healthcare assistant, social worker, chaplain, and the primary care physician, as well as volunteers. And there's also speech therapy, occupational therapy, and physical therapy if that's something that's deemed appropriate for the person's illness. The goal of hospice, again, is to make the patient comfortable. Pain management is the #1 key, and dignity. We want to do specifically what the patient desires. Another goal of hospice is to assist the patient and family in making legal and financial agreements, which includes advance directives, both the living will and the power of attorney for health care. These are written up specifically for the patient to make their wishes known regarding care with end of life when they're no longer able to speak for themselves. They can be very specific as to stating that the patient does not wish to have any kind of resuscitative measures done for them, be put on a life support, and they have the right to withdraw feeding tubes and things of that nature. Your role as a healthcare assistant, I will go a little more in depth with, and I'll start with the area of respecting the choices and the rights of the individual. It's very important for you to know that in hospice care and care of the terminal patient that the family and the patient are both involved in making the plan of care. So it's very well written out by the nurse and the family what they do and do not want, and you need to respect that. You want to encourage self-care as much as possible. If the patient is still able, remember that we want them to have quality of life. We don't want to take everything away from them. We want them to do what they feel they can do. So involve them in their cares. Example of letting them wash their upper body while you wash their lower body. And encourage family also. If family wants to be involved, family can be in there, not necessarily washing, but I frequently ask family to come in and participate in doing the massaging of the patient while I'm doing something else with them. You want to report any signs of pain or discomfort to the RN case manager that you may notice during doing cares with the person, be it they moan or grimace or something, and you can ask them if they're having pain. They may at some point deny it, but make that aware to the nurse so she knows what to look for when she is assessing that patient. You want to listen and be very honest in your discussions with them. Let the patient talk. Don't disagree with them, and you don't want to feed into anything negative. Just be an active listener and let them know that you're there to support them. During this time with them, you're gaining their trust, which is very important towards the very end of life. Quality care, you want to give this individual the same kind of care that you would give anybody who was not given a terminal diagnosis. They're living each day as if it was their last, so you want it to be the best that it can be for them. The physical signs of approaching death that you will note, the body does begin to start to slow down. You will notice the patient may start to be sleeping more or may want to eat less. For appetite decreasing, that's a very large area for families. They find it very difficult to not feed their patients. We're all grown up. When we were growing up, we're taught you have to eat to be healthy. And a lot of families have a difficult time with that. The way you can help is to give suggestions to the caregivers that they can offer small meals. People will be more open to trying something if there isn't a large amount of food on their plate. As someone's dying, they no longer have that desire to eat. So when they may view it, and I've had several patients tell me that if they don't clean their plate, it's it's a sign that they are dying, and we don't want them to have that feeling. So you want to offer frequent smaller meals. People also tend to crave colder foods towards death. You want to offer ice chips or sherbets or cold water, but again, at a very small amount, because their swallowing can also change as their body shuts down. Thicker things are usually tolerated much better than thinner things are, so I usually tend to stick with the sherbets and pureed foods or things of that nature, but refer to your nurse and ask for her guidance, and she will put that in the plan of care so that you know where you're at with that. Circulation also decreases as someone is declining, which is all part of as they become less active, they're lying around more, their body is conserving its energy, and the oxygen is focusing more on the vital organs in the body. You may start noticing changes in the skin color. Skin may become what we call mottled. It's a purple reddish blotching of the skin that can come and go. Family members may frequently ask if oxygen would help that, and normally the answer is no. Again, oxygen is a comfort measure. If the patient wants it, they're welcome to it. If not, they can decline that. They may become less responsive. Again, as the body shuts down, the kidneys and all of those vital organs that normally filter out the toxins in the body are no longer functioning at the capacity that they once were, so you'll notice a decrease in urine output, which is a sign that the kidneys are starting to fail, and those toxins are starting to build up in the body, which is kind of your body's own natural response to an anesthetic. It kind of puts you in that sleep. It does make you sleepier, which is a good thing at times where people don't require as much pain management. Their skin will become much more pale and dry at times. Their temperature can fluctuate. It's very important that you want to do frequent oral care and with toothette sponges if they're no longer able to swallow. That's a form of hydrating them. Their mouth becomes dry because they are normally mouth breathing at this time. You want to keep their skin moist by doing frequent massages with lotions and turning them from side to side. Temperatures are not always treated unless they appear to be a discomfort to the patient. The normal way that we treat them is just either cool tepid baths or just cool cloths to the forehead or to the extremities. You want to keep the lips in moist, very lubricated. There's several things out there. You can either use water or cool washcloth. You can use chapstick or Carmex, and we use, where I work, a specific moisturizer that can be used both on the lips and the inside of the mouth. Again, refer to your nurse and she can help guide you through that area. Repositioning, again, you want to pay particular attention to the bony prominences of the body because that person is now losing muscle tone and the inability to move themselves. Those areas are pressure points that you want to pay close attention